Endoscopic ultrasound-guided gallbladder drainage, transpapillary drainage, or percutaneous drainage in high-risk acute cholecystitis patients. A systematic review and comparative meta-analysis. Introduction. Acute cholecystitis is usually treated by laparoscopic cholecystectomy as the standard of care. In situations where patients are not fit for surgery, percutaneous or endoscopic routes can be used to decompress the gallbladder. Percutaneous options for gallbladder drainage, GBD, include simple needle aspiration or percutaneous gallbladder drainage, PCGBD, that is traditionally done via interventional radiology with the placement of a double pigtail plastic catheter as the drainage tool. Technical success rates with PCGBD range from 97% to 100%, with clinical success in the range of 56% to 100%. PCGBD has its limitations, however. Adverse events in the range of 10% to 12% have been reported, and worsening of cholecystitis is in the range of 25% to 50%. Endoscopic options to drain the gallbladder have evolved rapidly in recent years. Options include endoscopic transpapillary gallbladder drainage, ETGBD, and endoscopic ultrasound, EUS-guided gallbladder drainage, EUS-GBD. ETGBD and EUS-GBD have the advantage of offering the patient internal drainage without the need for percutaneous tubes, with all of their attendant downsides. Several studies have compared the performance of EUS-GBD and or ETGBD with that of PCGBD, with conflicting results. As a result, the role of endoscopy in the management algorithm of acute cholecystitis has not been confirmed. Furthermore, data comparing ETGBD and EUS-GBD are limited. Babu et al. Conducted this meta-analysis to better understand and compare the clinical outcomes of ETGBD, EUS-GBD, and PCGBD in high-risk acute cholecystitis patients. Background. Endoscopic transpapillary gallbladder drainage, ETGBD, and endoscopic ultrasound-guided gallbladder drainage, EUS-GBD, are alternatives to percutaneous gallbladder drainage, PCGBD, for patients with acute cholecystitis who are unfit for surgery. Data comparing these modalities are limited and have reported conflicting results. Methods. The authors searched multiple databases from inception to May 2019 to identify studies that reported on ETGBD, EUS-GBD, and PCGBD in the management of acute cholecystitis in patients with a high surgical risk. Aims were to compare the pooled rates of technical success, clinical success, adverse events, and disease recurrence. Results. 1,223 patients, 22 studies, 557 patients, 14 studies, and 13,351 patients, 46 studies, were treated by ETGBD, EUS-GBD, and PCGBD, respectively. The pooled technical and clinical successes were ETGBD 83%, 95% confidence interval, CI, 80.1 to 85.5, I squared equal 29, and 88.1%, 95% CI, 83.6 to 91.4, I squared equal 50, respectively. EUS-GBD 95.3%, 95% CI, 92.8 to 96.9, I squared equals 0, and 96.7%, 95% CI, 94.0 to 98.2, I squared equals 0, respectively, and PCGBD 98.7%, 95% CI, 98.0 to 99.1, I squared equals 0, and 89.3%, 95% CI, 86.6 to 91.5, I squared equal 84, respectively. Clinical success with EUS-GBD was significantly superior to the other approaches. All complications were comparable between the groups. Pancreatitis occurred with ETGBD in 5.1%, 95% CI 3.5 to 7.3, whereas bleeding and perforation occurred with EUS-GBD in 4.3%, 95% CI 2.7 to 6.8, and 3.7%, 95% CI 2.3 to 6.0, respectively. Stent migration occurred with PCGBD in 7.4%, 95% CI 5.5 to 10.0. Conclusion. EUSGBD demonstrated better clinical success than ETGBD and PCGBD in the management of acute cholecystitis patients at high surgical risk.